Okay, perfect. Nice to meet everyone again. It's always convenient to do this by Zoom instead of being in a stuffy auditorium. But for those of you who don't know me, my name's Andrew, and I'm one of the respirologists at Scarborough Health Network General Site. And I'm here to give a brief update on, what's new in the world of interstitial lung disease in 2024. The last time that I gave a talk was actually pre-pandemic in 2018. Talked about updates in therapy at that time. So just wanted to give another brief update on what's changed in the last few years, outside of that little thing called the pandemic. Okay. So here are some of my disclosures, I'd like to thank Boehringer actually for providing some of the slides that I'll be presenting today. So objectives of the presentation today is to review the epidemiology of ILD, to review in general what fibrotic interstitial lung disease is, brief overview of IPF management. I think a lot of us are familiar with this, so this will be very quick. Updates in fibrotic ILD management, and I'll end off by talking about IPF exacerbations, which is more relevant for our internist attending these rounds, and the new up-and-coming American College of Rheumatology ILD guidelines, which are controversial to say the least. So epidemiology. Not a lot is actually known in terms of epidemiology for interstitial lung disease. It's not the most common condition, but it's also not the most rare. Some of the estimates are, from the 90s and early 2000s. For example, there's about 20 to 30 patients with ILD in general that was estimated in the 90s in the States. Idiopathic pulmonary fibrosis, which has been considered to be the most common cause of ILD in the elderly population over the age of 60. It was estimated to have an incidence of about 9 to 18 per 100,000 people in the 2000s. Now, one of the reasons why it's so difficult to obtain epidemiological data on ILD is because it's not the most it's not easy to diagnose. No, it's easy to recognize that there's a bit of fibrosis on the chest X-ray or CT scan, but to actually get to the diagnosis of exactly what the patient has is quite difficult. And one of the reasons is because of this alphabet soup, basically. IPF is only one of many different types of interstitial lung disease. So the idiopathic pneumonias, which is the alphabet soup, we have our NSIPs, PPFVs, DIPs, AIPs, LIPs, COPs. That's the alphabet soup. Then we have our autoimmune ILDs. So anything that's caused by underlying rheumatological conditions. So RA, scleroderma, myositis being the most common. Then there's exposure related. We've all heard about bird fancier lung in the past. That's a form of hypersensitivity pneumonitis, but there's a lot of other things, other exposures that can cause ILDs. There's also ILDs that are associated with cystic lung disease, including lymphangioliomyomatosis, LAM, LCH, and last but not least, sarcoidosis. And as I mentioned, diagnosis of ILD, diagnosing a patient with a proper diagnosis of exactly what ILD they have, whether it's IPF or something else, it involves a lot more than just imaging. So it's important to, when you have someone that you're suspected of having fibrotic ILD, you need to do your proper assessment. History is actually very paramount. When I see an ILD patient in the office, along with my colleagues, a lot of time it is actually spent just teasing out exactly whether they have any exposure history or other type of risk factors that could have caused the ILD. CT chest is very important. never make a diagnosis of ILD on chest X-ray alone. You need a CT chest, ideally a high resolution CT. But a lot of the details can be obtained on just regular non-contrast CT or CTPE even. Sometimes people need lung biopsies, whether it's a surgical lung biopsy or a new modality called transbronchial cryobiopsies, which are being done more in Asia and in Europe these days, and more it is being offered in Canada too, although it's still pretty rare. And also multidisciplinary discussion. That's the gold standard for obtaining a diagnosis of ILD, MDD involving the respirologist, what the radiologist plus or minus pathologist plus or minus rheumatologist to talk over the case and get to the diagnosis of ILD. Now, again, there's lots of different causes of fibrotic ILD, and as I mentioned, we spend a lot of our time, in history taking, just going through whether patients have any of these exposures. Does the patient have underlying connective tissue disease? Not infrequently, we actually, we don't diagnose scleroderma. We always send it to our rheumatology colleagues. But we have I have a handful of patients that I've suspected of having scleroderma who ends up having scleroderma or systemic sclerosis when I see them in clinic. Substance exposure, drug exposures. Some of the drugs that we're interested in are things like amiodarone, nitrofurantoin therapy, TNF-alpha inhibitors. Methotrexate is historically one of them, but that's controversial. Radiation therapy. So lots of different etiologies of fibrotic ILD. Now, as I mentioned, epidemiological data is very limited, but Canada actually is lucky because one of the ILD doctors in TGH, she's leading this multi-center prospective registry data set, and it's basically just cohorting anyone that was seen in one of the ILD centers, TGH being one of them, Firestone, Epic Master being another one, who is above the age of 18, with any fibrotic ILD of any type, and just cohorting them into an epidemiological data set. And this has actually given a lot of insight into more insight into ILD. For example, we've always considered IPF being the most common cause of fibrotic lung disease. But the CarePF data, the Canadian registry for pulmonary fibrosis data, shows that IPF is actually just one of the fibrotic lung disease that we see in our population. A large proportion of them are actually autoimmune related, so CTD-ILD, hypersensitive pneumonitis, so exposure related, sarcoidosis, unclassifiable are ones that cannot be clearly put into a certain diagnostic category after all the investigations have been done in MDD. And unclassifiable ILD, it does actually make up a significant portion of the ILDs seen in the CarePF data set. 20 to 25% of patients actually. Just looking at the baseline characteristics, ILD still, regardless of whether you have IPF or other types of ILDs, it still remains a condition of older age. So the average age of IPF patients are over the age of 70. Fibrotic ILD in general is over the age of 65. So it's not something that we consider, and we consider less in younger populations. So a brief overview on IPF. Not all ILD is IPF. Not all fibrotic lung disease that we see on a CT chest is IPF. IPF is a distinctive diagnosis. It's a specific form of chronic progressive fibrotic lung disease, which occurs in older individuals. And clinical course is variable and unpredictable. I always explain to my patients that, it's predictably unpredictable. You can have, patients that are very stable for many years. You can have patients that, have significant deterioration very quickly. You can have acute exacerbations. Those, so it's very unpredictable. Usual interstitial pneumonia or UIP, that's the radiological and pathological terminology that leads to the diagnosis of IPF. And the reason that diagnosing IPF is very important is because it has a dismal survival. We all, when we talk to our patients in the office and we tell them, look, you don't have lung cancer, from all our investigations, but you have idiopathic pulmonary fibrosis. They, give us a sigh of relief. But I always have to reorient them to tell them that, it's actually not, the survival rate is actually quite poor compared to, other types of cancers, especially breast cancer is one that, that's one of the most common. It has a worse 5-year survival rate. It's actually closer to lung cancer in terms of survival. And the survival, this is an old data. So this is before the advent of checkpoint inhibitors. So, the checkpoint inhibitors have improved the outcome of lung cancer patients. So, it's actually even closer in terms of mortality. So, progressive fibrosing ILD is a terminology that's been thrown around in the literature, and basically what it's telling us is there are certain types of interstitial lung disease that progress. IPF, just by definition, is a progressive fibrosing ILD. All patients with the diagnosis of IPF, they progress. But there are other types of ILDs, including HP, CTD ILD, things, exposure-related sarcoidosis, some of which are just have an acute phase in their illness, or subacute phase, and don't actually go on to to progress into a fibrotic pattern. But we also know that a lot of these, these ILDs were not IPF, but we follow them all along in the clinic, and they, continue to progress. They continue to have fibrotic lung disease. They actually end up behaving very similarly to someone with IPF. And because of this, the American Thoracic Society has moved towards formalizing a definition of what these, progressive fibrotic interstitial lung disease is. And they've started to, and this is what some clinical trials have looked at. Some of the antifibrotic medications that's been used in IPF in a wider population. And what they have come up with is a new terminology called progressive pulmonary fibrosis, or PPF. And basically, PPF, this is a very wordy slide, but PPF is basically interstitial lung disease that's not IPF, who has progression of their condition. And progression is defined as having two of these three factors. So progression of their symptoms, progression of their physiology, so decline in their forced vital capacity or diffusion capacity, or progression radiologically. So worsening fibrosis, worsening ground glass opacity, worsening reticulations. Any progression that we're seeing in their underlying lung disease on the CT scan. So if you have any two out of the three, then and you have interstitial lung disease that's not IPF, you have progressive pulmonary fibrosis. And as I mentioned, when we see a lot of our patients who don't have IPF but have this, fibrotic, who have some type of fibrotic lung disease that we follow along, a lot of us have anecdotally noticed that they don't do well. They may not have IPF by definition, but they progress just like someone with IPF. And their clinical course is variable. They can have exacerbations, so it can be unpredictable. They have high mortality. Their fibrotic lung disease progress to the point where they will pass away from their condition. So And this is just I'll get into the details about the impulses and the in-build studies later, but impulses was looking at the IPF population, and in-build is looking at this new progressive pulmonary fibrosis population. When we actually follow the placebo group, so the patients that were not on medication in both of these studies, regardless of whether they had IPF in the impulses group or other fibrotic lung disease that progressed, they're losing lung function quite similarly. At the 1 year mark, the 52-week mark, a lot of these patients are losing 150 to 200 milliliters of lung forced vital capacity. To put it into perspective, regular normal individuals will lose anywhere from 10 to 20 milliliters of lung function just from regular exposure. So IPF and fibrotic ILD populations don't do well. So brief overview about treatment of IPF. So treatment of IPF involves a lot of different things. Pharmacological is just one of them. Looking for comorbidities, symptom control with palliative care referral early on, lung transplantation referral at a certain point. But I'll focus more on the nintedanib or OFEV data for this talk. So tomorrow is a phase 2 study that looked at nintedanib in idiopathic pulmonary fibrosis, and impulses is the phase 3 study that looked at nintedanib for idiopathic pulmonary fibrosis. And when we pool the data, when we combine both of these data, what we find is, definitely nintedanib is effective in reducing the loss of lung function, loss of forced vital capacity, on average of more than 200 milliliters per year to about 100 milliliters per year. So that's about a 50% improvement. Even before pooling them, if you separate out the tomorrow and the impulses trials, it showed similar data. The reason that the pool data is important actually is because the pool data definitely showed an improvement in the exacerbations. So impulses, the phase 3 trial, those were actually it was actually two concurrent trials. It was impulses 1 and then impulses 2. Exactly the same design of the trials, but they just did the two trials concurrently, and only one of them actually showed an improvement in exacerbation. Impulses 2 did, not impulses 1. But if you actually combine both impulses 1 and 2 and the tomorrow data, which is the phase 2, there is a definite improvement in improving the exacerbations for patients that are on nintedanib or OFEV. And there's a definite improvement in mortality for patients on nintedanib too. It's hard to convince our patients to take these medications, when we're talking about, it improves lung function, it improves exacerbations. When we can tell them that, look, by being on this medication, you have a significant survival benefit. You live longer, you're going to live longer by about 30-40%. That shows a definite benefit that our patients can understand more easily. Cardiovascular disease and cardiovascular risk is actually something that was studied carefully after the trials came out, after the impulsive trial came out. So post-hoc analysis actually looked at whether nintedanib actually increases the number of cardiovascular events, because there was a small signal towards more MIs and more cardiovascular events in the impulses trials. And what it did show is If you don't have a lot of cardiovascular disease, if you don't have established coronary artery disease, and you don't have any significant risk factors for atherosclerosis, so the metabolic syndrome, hypertension, dyslipidemia, diabetes, no former smoking, you don't have much to worry about. But if you do have a lot of risk factors, there is definitely an increase in the risk of cardiovascular disease. But that being said, the absolute numbers were quite low. We're talking 10 to 20 patients having major adverse cardiovascular events in pool studies, that looked at, 3,000 patients. So, there is it is something to consider, but personally, when I'm trying to determine whether to put patients on the tentative or not, having cardiovascular risk factors, having established coronary artery disease actually doesn't enter into the equation of whether to recommend therapy or not for me and for and for the vast majority of respirologists, including the ILD specialists. As I mentioned, IPF is a condition that's more common in the elderly, and just anecdotally, the our older populations, we do find that they have more side effects, and we are definitely more concerned about them because they just have more comorbidities. So looking at whether there's a significant difference in the in how well nintedanib works in the elderly population and what the side effects are, dividing out the trials to patients less than 75 and more than 75, it works similarly. Just because you're older doesn't mean that the drug loses its effectiveness. In terms of exacerbations, there's an improvement in the number of improvement in exacerbations as well too. In terms of side effects, again, very busy slide. But as a lot of you guys know, diarrhea is the most common side effect associated with use of nintedanib, and that remains the case whether you're younger or older. There's no other GI side effects or no other significant side effects that came about because you're over the age of 75. What we did find was, though, if you're over the age of 75, there was patients with side effects did tend to terminate their treatment earlier on because of the side effects. And this is actually seen anecdotally in our clinic too. I do find that, in the elderly population, they do tend to have more significant diarrhea. Compared to someone that's relatively younger. And when they do have the diarrhea that's severe, they're going to want to stop the therapy, regardless of what the benefit is. So in summary, in the idiopathic pulmonary fibrosis population, nintedanib definitely effective in reducing the rate of forced vital capacity decline, reducing exacerbations, and there's definitely a mortality benefit. It is relatively safe to use in cardiovascular populations, but it's just something to keep in mind, though, that there is an increased risk in cardiovascular events, and in the elderly population, it's both effective and safe to use. Now, when we look at these CT scans, again, it's hard to know whether a patient has idiopathic pulmonary fibrosis or hypersensitive pneumonitis or CTD-ILD or another type or another one of these fibrotic ILDs that I mentioned to you. I think if I remember correctly, I think this patient, the one on the left had IPF, the one on the right had CTD, and the one in the middle actually, I think is HP. But when you're looking at these patients on the CT scan, there's not a lot of difference in terms of not a lot of difference that can be identified in terms of the pattern of fibrosis, and that's one of the reasons why we've decided to combine these fibrotic lung disease into a more definable entity called progressive pulmonary fibrosis, or PPF. And again, just to review, PPF are ILD patients without IPF, so you have to rule out IPF beforehand, who have any two out of the three of the following, worsening symptoms, worsening PFT, and worsening CT scans. And when we look at the non-IPF population with fibrotic lung disease in the CARE-PF data, the Canadian registry data, we find that quite a significant proportion of patients do meet the criteria for PPF. Now, this study that was done by Nathan Hembley at McMaster, the definition of progressive fibrosis was slightly different. It did include mortality, someone that died from their lung disease, someone that had progressed to transplant, and that include patients with a slightly lower vital capacity decline, I think. But overall, close to 50% of patients without IPF progressed. They had this. They could be classified as having this progressive phenotype. And again, why is that important? We know that IPF patients do poorly, and IPF patients have a high mortality. And a lot of these data do show that the IPF and the fibrotic lung disease, HP here, hypersensitive pneumonitis, they progress at a very similar rate. This is data from 2010, looking at rheumatoid arthritis ILD. We've known since, for more than a decade that, people with rheumatoid arthritis related interstitial lung disease who have this UIP pattern or, basically, fibrotic pattern under CT scan, what, that traction bronchiectasis, honeycombing, classic for, classically associated with IPF. They do fairly, in terms of their survival and their mortality, they're almost in line with someone that has IPF. So because of all of this, we started to look more and more into whether the medications that we've been using for IPF patients would be beneficial in this wider population of patients with fibrotic lung disease, especially with this progressive pulmonary fibrosis phenotype. So this trial, this is already 5 years old, but it just we've only had this study came out 5 years ago, but Health Canada approval for use of the medication nintedanib in the population in Canada actually started last year. So that's why it seems newer to me. But basically, this study looked at whether nintedanib, which is one of the medications that's been shown to be beneficial in IPF patients, are also beneficial in this progressive pulmonary fibrosis patients. It's called the INBUILD study. And INBUILD study, again, is a randomized double-blind controlled study looking at nintedanib 150 milligrams twice daily versus placebo, 1-to-1 allocation. And it looked at whether it met similar primary and secondary endpoints. So forced vital capacity decline, exacerbations, mortality, exactly the same things that we looked at in our IPF population. And in the INBUILD study, the patients, it involved a lot of different types of fibrotic lung disease. So again, we're looking at non-IPF populations. So IPF patients are excluded from the study, but we're looking at fibrotic lung disease caused by a lot of other things. So hypersensitive pneumonitis, CTD ILD, or autoimmune related ILD. Other types of ILDs, including, sarcoidosis, radiation fibrosis, unclassifiable ILD. So these are the things. These are the populations that we looked at in the INBUILD study, and what it showed is in the overall data set, yeah, it definitely improves lung function. So, in the placebo group, with fibrotic lung disease, you're losing close to 200 milliliters of lung forced vital capacity by the end of the year. in the original Impulse study for IPF, the placebo group was losing about 200 milliliters, 200 cc's of lung volume. So very similar in terms of placebo. And nintedanib decreased that by greater than 50%. Which is very similar to the benefit that we saw in the IPF population. When we divide out the population into patients, on their CT scan, did they have this usual interstitial pneumonia pattern, UIP pattern under radiology? Regardless of whether they had UIP pattern or non-UIP pattern of fibrosis, they still had a significant improvement. If you had UIP pattern would be, you have honeycombing, you have, traction bronchiectasis and reticulation. You had a greater benefit with the medication. But even if you didn't fit the definition, the Fleischner definition of UIP radiological pattern of fibrosis, you still had a significant improvement. And this is just showing that data, showing that data in a plot. Now, exacerbation, it also improved the exacerbation rate. So, in the placebo group, in the placebo group of fibrotic lung disease, patients were exacerbating at around 18%. Whereas in the patients that were treated, that with nintedanib, that got decreased to about 12.3%. When we're teasing out the different type, the individual types of fibrotic lung disease, again, it's very uniform. So hypersensitive pneumonitis, autoimmune ILD, NSIP, other types of IIPs, connective tissue disease related ILDs, including scleroderma lung disease, they all demonstrated improvement in reducing the rate of forced vital capacity loss with nintedanib versus placebo. Now, nintedanib isn't the only medication that's available for our pulmonary fibrosis, for our idiopathic pulmonary fibrosis patients. It's the most commonly prescribed, but pirfenidone, or Esbriet was the trade name. That was actually the first. That was actually the first one that was approved by Health Canada by about 1 or 2 years. And we did look at pirfenidone to see whether whether there was improvement in the outcome of fibrotic lung disease by using pirfenidone. And although it didn't, the trial didn't pan out, there wasn't enough recruitment in the trial, and also didn't demonstrate statistical significance in the middle when they were conducting the trial. But there was signal towards improvement, like in our in-build study with nintedanib. Now, this isn't the in-build study. This is actually the Census trial. Census trial was actually another study released in 2019. I'm not going to go into it much in detail, but that looked at just scleroderma lung disease. Scleroderma lung disease actually, scleroderma-related ILD actually did enter into the in-build trial too, but they did do a completely separate trial looking at just scleroderma lung disease. And for scleroderma lung disease patients, yeah, they using nintedanib also decreased the rate of lung function decline by about 50% too. So in summary, for patients that have progressive pulmonary fibrosis, so these are PPF are patients that basically have fibrotic lung disease that are progressing, symptom-wise, radiologically, and physiologically, that do not have IPF. Nintedanib is effective. And the effectiveness is very similar to patients that receive it that have IPF. And as I briefly mentioned, although these studies were back in 2019, were released in 2019, Health Canada approval was actually just last year. So actually it might be 2 years now, 2022, I think actually. So we've only been using it in our broad population for the last couple of years. Now, with these with these medications, what does that mean in the real world? Deborah, who is one of the respirologists in Montreal, she looked at the CARE-PF data, which, as I mentioned to you, is the Canadian Registry for fibrotic lung disease, to see to see whether these fibrotic ILD patients, including IPF patients, actually got on treatment. Because now we know that for IPF patients, there is a very, very effective treatment that actually improves mortality. For fibrotic lung disease patients, there's also treatment available too. One caveat to the study, she looked at the patients from 2015 to 2020, so before Health Canada approval for use of nintedanib in the fibrotic ILD population. But we were treating those patients with immunosuppressants like prednisone, mycophenolate, azathioprine before that. And what this study showed is, despite having these approved therapies that are known to be effective, only about 50% of our patients actually get on therapy. Only about 63% of IPF patients will be on treatment. Namely what one of the antifibrotics, nintedanib or pirfenidone, and about 50% of the non-IPF ILD patients would be on treatment. In this study, it would have been with prednisone, with azathioprine, mycophenolate. Very seldomly, it would have been rituximab. So, we could do a lot better with the knowledge that we have as respirologists with, starting patients on appropriate treatment. Now, acute exacerbations of IPF or acute exacerbations of ILD. This is what we deal with on the consult service as respirologists. What our ICU doctors deal with on ICU, and what our internists especially deal with on the medicine service. Patients that are coming in with a history of IPF or ILD with some acute worsening. Incidence varies. Again, IPF and ILD in general is not the most common condition, and exacerbation of IPF is even less common. But previous trials, both in Asia and in the States, have shown that anywhere from 10% to up to 50% of patients will get some type of exacerbation during their disease course. What we do know is prognosis is poor. For definite ILD or IPF exacerbation, if a patient is admitted with a true exacerbation, you have about a 50% mortality at the 30-day mark. If you have a patient that has an exacerbation that's requiring invasive ventilation, so in the ICU ventilated, your mortality is close to 100%. Actually, it's like 99.99%. And even if you happen to survive at the 30-day mark, the median survival is only about 3 to 4 months. So if you actually do have a true exacerbation, you're very, very sick. And you have a very high chance that you're not going to make it out of the hospital alive. And there's a lot of variable definition of IPF exacerbations. I'm not going to talk about ILD exacerbations in general because that hasn't even been defined. But in terms of IPF exacerbations, there's no consensus definition. The one that we tend to use is the one proposed by Harold Kohler back in 2016. And it's basically patients with IPF coming in with worse symptoms, typically less than a month. And you rule out other factors. So you rule out things like a PE or like pneumonia, pneumothorax. You rule out heart failure, drug toxicity, aspirations. And once you rule all of that out, by doing, CT scans, namely, but also, echocardiograms, obviously, history and physical exam. Once you rule all of those out, then, you can diagnose them as having an acute exacerbation of IPF. This means that just because a patient has underlying IPF and is coming in with some type of worse symptoms, it doesn't mean that they have an exacerbation. And actually, telling someone that they have an exacerbation of their IPF, because it has such a poor prognosis, and high mortality, it's not something that should be lightly be diagnosed. So, it's only when we really we can suspect an exacerbation, but we have to really rule out, especially things like, heart failure. Now, the CT scan, so these CT scans are coming from the same patient, and actually the one on the left is pre-exacerbation CT. So you have your typical UIP pattern with honeycombing, traction bronchiectasis, and on the left you see a lot of, chlorine glass opacities, these areas of whiteness that we see on the CT scan. So this patient actually had an acute exacerbation of IPF, and the patient did have CT scan, echocardiograms, blood work to rule out other causes. Now, as I mentioned to you, CT scan is CT scan has to be done for these patients. If you're suspecting an exacerbation, X-ray is not enough. Even if they've had a CT scan 2 weeks ago or a week ago, as an outpatient, if they're coming in with with acute worsening of their deterioration in their symptoms, you need a CT scan. HRCT is ideal, but because PE needs to be ruled out as well too, I actually generally tend to do just a CTP, recommend just a CTPE. In that case, you can rule out a PE, and in general, you have enough, you can see enough to get a sense of whether someone's having an exacerbation. If the CTPE doesn't provide enough resolution, then we can always, send the patient back for another proper HRCT scan. But in this study, this is actually not part of the CARE-PF data set. This was actually a European data set. Actually, no, not just European. Actually, they looked at multiple centers in Europe, North America, and in Asia. CT was almost always done. Bronchoscopy was done for some patients, and the patients that did receive a bronchoscopy were someone that had a high suspicion of infection and had low oxygen requirement. So if someone is actually on a high flow oxygen, or even above 5 to 6 liters, it's given that they're elderly population, it's actually it's not safe to do a bronchoscopy on these individuals. And then in fact, we rarely would recommend doing a bronchoscopy on someone that we're suspecting of having an IPF exacerbation. KL6 is a blood marker that's actually more commonly done in Asia, and it's been studied to look at whether it actually represents IPF exacerbation. In terms of management, again, there's no consensus here. Some people get steroids. Most people will get steroids. The minority of patients will not get any steroids. Lots of people will get antibiotics, just on spec, just in case there's an infection here. The general steroid dose that we would recommend is high dose. We're talking Solu-Medrol 500 to 1,000 milligram, not just not 40 BID. And after that, some people will taper it slowly. Some people will do 1 weekend to stop. There's a lot of variability. Whether antifibrotics have a role when patients are having an exacerbation, about 30% of the patients in this study did have initiation of pirfenidone and nintedanib during their acute exacerbation. But these patients were exclusively in Asia, where actually mostly in China, where it was more readily available. In Canada, we would never start these patients on nintedanib or pirfenidone. The data just doesn't support it, but also the medication requires the AP approval, application to the government. We're not going to be able to get patients on the antifibrotics in the short term. And in this particular CT scan, the one on the left is showing that ground glass opacity that diagnosed this patient with an exacerbation. This patient received 1,000 milligrams of tolumetrol for 3 days, followed by milligram per kilogram of prednisone for the rest of the week. And it showed a significant improvement in the ground glass opacities. And this patient actually, specifically, actually ended up doing very well. Changing gears a bit, so not looking at the exacerbation patients, but in terms of diagnosing what type of fibrotic ILD patients have, whether we send patients for lung biopsy or not, it's actually getting more and more controversial. There was a time period where everyone basically got a lung biopsy, and then people just never got sent for a lung biopsy. And now we're starting to consider whether there is a role for lung biopsy now. But one thing is for sure, transbronchial biopsy, just on the bronchoscopy, useless. It doesn't provide any lung architecture because the samples that we get on the transbronchial biopsy is too small. It's enough to diagnose someone with malignancy, but definitely not enough to diagnose the type of fibrotic ILD patients that they have. Surgical lung biopsy, where they take 2 or 3 different small pieces on the vats from the lung. Minority of our patients get sent for a surgical lung biopsy, and especially because it is a big surgery in our elderly population, if they have a quite advanced disease, this is actually that we would forgo as well too. Transbronchial cryobiopsy is something new that's being used more and more. They're using it more in Asia and Europe actually. When I actually went to Germany last year, every patient with an ILD diagnosis were getting a transbronchial cryobiopsy, like 100% of patients. But that's not the case in the States and in Canada. And in fact, the only center in Ontario that's doing it is TGH by Dr. Yasufuku, one of the thoracic surgeons, and actually Kasha, who's one of the interventional pulmonologists. And they really select their patients carefully because they've actually had a lot of side complications from the cryobiopsy because there is a greater risk of bleeding and pneumothoraces. And also there's still controversy about how much information the transbronchial cryobiopsies can provide. And actually in one study, it actually showed that there is a large amount of discordance between what we see on the surgical lung biopsy, big, large pieces, versus a transbronchial cryobiopsy. Still controversial whether it would have a large role in the diagnosis of ILD. Now, last but not least, just wanted to mention to you guys about the new interstitial lung disease guideline that's being put out by the American College of Rheumatology. Some of it is out, but the full guideline is actually not yet released. It should be released sometime this summer, early fall. But it's already causing a lot of controversy, both amongst the rheumatologists and the respirologists. And the reason for that is because they're very liberal in recommending screening and also monitoring tests for patients. So what they're saying is for anyone that have underlying autoimmune disease, autoimmune rheumatological condition that is at a high risk for ILD. So we're talking about rheumatoid arthritis, scleroderma, myositis patients. They're saying everyone should get a PFT. Everyone should get a CT scan at baseline. And not only that, even after they get it, and even if their test results are normal, they're recommending, every 3 to 6 months of, PFTs, every annual CT scans as monitoring. Now, it's a guideline. It's a guideline recommendation. But anecdotally, what we're hearing from, especially amongst the respirologists, is this is backed up by very little evidence, and this is actually not feasible in the real world. And just to finish off, this is the last slide of the presentation. Methotrexate. We've always talked about methotrexate as being one of the medications that can cause fibrotic lung disease. What we notice more and more now is methotrexate can cause an acute or subacute type of interstitial lung disease, but fibrotic lung disease, so chronic progressive fibrosis is actually quite rare. And in fact, there's even some data to show that patients that are on methotrexate, methotrexate, so RA-ILD patients that are on methotrexate, they actually derive some benefit from the methotrexate. So still very, still controversial. I think the vast majority of the respirologists will avoid methotrexate use, definitely if they have underlying ILD. And, for someone that has new RA-ILD, we would, definitely ask our rheumatologist to be very, very cautious, and consider other therapies before methotrexate. But, methotrexate is actually not as dangerous for the development of fibrotic ILD as we initially thought. So that is it for the presentation. So thank you very much for everyone's time. I'd be happy to take questions if anyone has any. And if there are no questions, then I'm very happy about that. Happy with that as well too. So thank you very much again for your time. And hope everyone has a great rest of the day.